Okay, madam. Okay.
Yes, ma'am, we are live now, ma'am.
So, yeah, can we have the CV sets, please? So, I welcome all of you for the Pinnacle series. So, today's topic for discussion would be the fibroid uterus. So, we have the societies which have been participating today will be Meerut Society, Ranchi Society, Aurangabad, along with Oxy Chennai societies. So, welcome all the faculties and the delegate. Can we have the next slide, Sahiti?
Yes.
So, I would request everybody to join for the invocation song. Thank you. I would like to hand over. Invite everybody to join for the lighting of the Kuttuvilakku. So I would like to invite Dr. Madhumita Arun Karthik, a consultant obstetrician gyne and reproductive medicine from Salem, resident of Salem with the EC member of Oxcox, and she will take over as a MOC today.
Thank you so much for the kind introduction, ma'am. I would like to introduce my co-MOC, Dr. Priya Kannappan, who is a consultant obstetrician gynecologist at Chennai and also the executive council member of Oxy. Next slide, please.
Madhumita, we will proceed
Yes,
with the
yes, ma'am.
program.
Yes, ma'am. It is my pleasure to introduce Professor Dr. Sampath Kumari, ma'am, who is the convener for this wonderful
problem,
Pinnacle
Madhumita,
webinar series.
Thank you, thank you, thank you.
Yes, ma'am.
So I welcome you all, Usha madam and Pardesi sir, and all the president and secretaries of the Meerut, Aurangabad and Jharkhand and our own Chennai society. First of all, I thank Dr. Usha madam for accepting to be the chief guest. They have another program also today, I think.
Yes,
so
that
this
is at 5
Pinnacle is,
o'clock.
yes, madam. This is a series which taking societies from north, east, west, and south. So without wasting time, I want to get the blessings from our Usha madam. Sakiti, can you place the CV of Dr. Usha madam?
Actually, संपत्ति से छोड़ दो, but photo हो
Yes,
गई.
I am not able to see that. Usha madam is the director general, and the madam has got the wonderful Padma
कैमरा
Shri award.
कैसा हो गया? चलो ठीक है.
And Director General Medical Education, Uttar Pradesh, Principal cum Professor of Gynecology and Obstetrics, LLMR, Medical College.
I think Sampath, it's enough.
Madam is Usha madam is the what to tell, the god of north side. I can tell with all blessings, Usha madam. Few words and blessing of our Pinnacle series. Yes, madam. Welcome, madam.
Thank you very much, Sampath. I think I am audible. Okay.
Yes, madam. You are audible.
Okay. It is a great pleasure for me to be a part of such a wonderful Pinnacle new series, episode 17. And actually, I will tell you, Sampath, we never knew about this, that you are having monthly series with different societies on different subjects. It's really very, very important and very helpful for everyone. And when you told us that now you are going to have another series in which Merit Society will be actively participating, like our very dynamic secretary, Dr. Priyanka Garg, who is a great endoscopist, and Dr. Bharti Maheshwari, the president. And today we have with us Dr. Rajendra Pardesi as a guest of honor, Dr. Ajay Mane and Dr. Shashi Bala. Unfortunately, they are not here, but Dr. Rajendra Pardesi was just now with us and we were talking to him. And we all know that today's this Pinnacle news series is on fibroid uterus. We also note that the fibroid uterus is an enigma and a unsolved. And it was long back, it was quoted like this: if the uterus does not sow seed, it sows weeds. And so many times they used to say कि भैया जो sterile होते हैं उन्हीं लोगों में ज्यादातर fibroid होते हैं. And we also know that India is the PCOS capital of the world. Hyperestrogenemia, hormonal imbalance, obesity is the root cause of incidence of fibroid. Earlier it was said that the fibroids, क्या हो गया कैमरा में क्या हो गया? पता नहीं क्या हो रहा
आ गया मैडम, आ गया
Now we can see,
पर वो
madam.
पता नहीं क्या होता है बीच में चला जाता है.
but voice is very clear.
अच्छा, earlier it was said that fibroids usually occur in reproductive age group. But nowadays we see small girls with puberty menorrhagia, and then at the menopause we also find endometrial cancers in the menopausal ladies. We have a basket of medical management available, including the mifepristone as well as uliprostone, and we also have GnRH analog, both antagonist and agonist. And we also always say that we should be prepared for every kind of thing, but it also depends on the surgeon. Will they like to give medical management? But sometimes only medical management does not suffice, and then we have to choose the surgical management. And we have also nowadays magnetic resonance guided focused ultrasonographic technique, which is very important and which is an advanced thing which can be used for the management of the fibroids. The surgical techniques, it can be done either abdominally or vaginally or endoscopically. We have with us our great endoscopic surgeon, Priyanka Garg, who will always say that we should do it endoscopically and not vaginally. But it all depends on the surgeon. Whichever the type of surgery she is well off, she should be doing that. And I'm very, very glad that this क्या हो रहा है पता नहीं इसको. अच्छा फिर आगे. अच्छा. So, Sampath, I really appreciate and admire that you have kept such an important topic, that is fibroid management, which is really, it has a very, very frequent incidence, and we should be well versed about the treatment and the management of fibroid, medical management as well as surgical management. And I wish this program will be wonderful, organized wonderfully well. And you have really thought of a very good subject, and everybody will be greatly benefited by this. I wish this program a great success. And while I will conclude, I will also like to wish all the best to Dr. Sampath Kumari, who is contesting for the post of presidentship. And I can tell you, she is such a learned person. She is a very sincere, hardworking person and has got academic excellence. And I'm sure that everybody of you from you will support her and will vote for her. So wish you all the best, Dr. Sampath. And again, I will really congratulate you for choosing such an important subject of fibroid uterus and its management, which will go a long way in updating the knowledge of each and everyone who are attending this webinar. Thank you very much for making me a part of such a prestigious webinar. All the best.
Thank you so much, madam. Madam is having another program by 4:30 in UPC. In spite of that, you have accepted. Thank you, madam. Always need your blessings, madam. Thank you so much for joining this webinar. This is conducting from December. I am conducting this, madam. Thank you
Yes.
so much, madam.
Okay.
Thank you.
Okay. Thank you.
Yes. Yes, we can go with our Pardesi sir's CV. Shahiti?
Yes.
Yes, it's okay. It's okay. We can skip that. The
1
slide is
minute,
there.
1 minute. No, sir, 2 lines I will tell. Dr.
Yes.
Pardesi sir was past president of Mamox, and he is the consultant at the Jijaji Maternity and Nursing Home. Of all this, he was a Foxy vice president and a best human being. I welcome you, sir, for the blessings of this webinar, sir.
So, good evening, everybody. Thank you, Dr. Sampath Kumari, for kind introduction. A respected chief guest and our grandma in all aspects,
Yes,
Dr. Usha Sharma, guest of honors, Dr. Ajay Mane, Dr. Sashibala, then Foxy chairperson, Dr. Archana Kumari, and organizer, Dr. Sampath Kumari, ma'am. Today, I am feeling really proud and honored to be a part of this program. First, I wish to congratulate Dr. Sampath Kumari and all 4 societies, that is Meerut, Ranchi, Aurangabad, and OGSSI, for organizing this episode of Pinnacle and actively participating in this new series on fibroid and vaginal surgeries. I don't want to comment more after our grandma, Dr. Usha Sharma, but with the galaxy of all faculties like Dr. Sampath Kumari, Dr. Bharti Maheshwari, Dr. Priyanka Garg, Dr. Archana Kumari, then Dr. Gomati, Dr. Sadhana Devi, Dr. Radhama Devi, Dr. Radhika Gauri, Dr. Rupali, Dr. Raute, and our active and energetic MOCs, Dr. Madhu Mita and Dr. Priya Kannappam. I think this is going to be a great event. I wish every success to Dr. Sampath Kumari for her future endeavor in Foxy in forthcoming election as president of Foxy. I wish every success to this webinar. Thank you. Thank you so much for inviting me.
thank you, sir. Thank you so much, sir. For within the short notice, you and Usha madam has accepted to be the chief guest. Yes, thank you, sir. I think Dr. Ajay Mane and Shashibala madam is not there. When they join,
Ajay
we
sir
can.
has
Ajay
joined,
Mane sir
ma'am.
is here, ma'am.
Ajay
Ajay
Mane
Mane sir is here.
Ajay Mane sir has joined.
Yes,
Then
yes, yes.
welcome,
Sampath
Dr.
madam.
Ajay
Sir,
Mane.
sir.
Yeah, I have
Yes,
joined
Ajay
late.
Mane, sir.
Oh, sorry.
1 minute, sir. Vice President Foxy of 2024, and he was the
No, we'll
committee
skip
chair
that.
of Medical League.
We'll skip this.
Medi-
We'll skip this.
Yes, of this,
Yeah,
he is
please
one
change, please,
my
please.
best friend in Ajay Mane. Yes, welcome Ajay Mane for the blessings for this webinar. Welcome, Dr. Ajay Mane.
Yeah, to start with, I am very much thankful to Sampath Kumari madam that she has invited me as a guest of honor. I'm not that big personality. I'm her younger brother. And pranam to Usha Sharma madam. Madam ji, pranam.
Pranam,
As
pranam.
per this sir said it correctly, she is a grandmother of all of us in the field of knowledge, age, experience, everything. And Padma Shri Usha Sharma madam is here, so nobody should speak in front of her.
Oh, no.
Yes, respected Bharti madam, who is again my elder sister, Priyanka ji, who is again a family member of ours from Aurangabad Society, Shashibala ji, Archana Kumar ji, and then my own secretary Bhagyashri, and Dr. Meena. Vaginal surgery is the basic knowledge one gynecologist must possess, basically. So endoscopy and all the modern techniques we have learned, but the basic things are vaginal surgeries and MTPs. These are the 2 procedures which must be learned by any gynecologist. And today you are conducting the complete session on this Pinnacle episode 17. So I wish all the best for the episode and for a whole series. And more than that, I wish all the success to Sampath Kumari madam. And I assure her that we'll be with her for every endeavor in
Thank
the
you
Fox.
so much.
Best luck, ma'am. Best luck.
Thank you, Dr. Ajay, for the wonderful blessings
thank
and the
you very
wishes. Thank you. But Sahiti, Dr. Shashibala is there?
No,
No,
No, ma'am. No, ma'am, sir. Ma'am is not joined, ma'am.
no. If she is not there, we will proceed with our scientific session, I think.
Yes,
Dr.
ma'am.
Madhumita, introduce
Yes,
our
ma'am.
speaker, Dr. Archana.
Yes, ma'am.
Thank you, Usha Madam and Pardesi Sir and Ajay Mane Sir for joining in spite of the TUPCOG program. Anyway, thank you very much. And now
Thank
we'll
you.
go with the scientific session. Madhumita,
Thank you.
introduce
Yes, ma'am.
Dr.
Thank you so much,
yes.
Can I
Sampath.
say a few words,
I'm
Dr.
sorry that I will
Sampath
have
Kumari,
to
madam?
leave, but
Yes, madam.
thank you.
Yeah,
Yes.
good evening and Bharti Maheshwari here. So first of all, before our special chief guest and guest of honor, they go from the webinars, I just say good evening to every one of you and
Yes.
just want to say thank you very much from bottom of my heart for continuous support for last year, not for my election, but for always for encouragements and everything. So thank you very much. What I want to say and congratulations, Sampath madam, that you have bring all together 4 societies, very important societies, and chief guest none other than Professor Padam Shri Usha Sharma madam, as well as guest of honor Dr. Padeshi, Dr. Ajay Mane, Dr. Shashi Bala, and in fact all persons who are present in today's webinar, we all are very close to each other, not only academically but socially also. So thank you very much, everyone.
Thank you, Dr. Bharti. Thank you, Doctor.
Yes.
Yes.
Thank you so much, ma'am.
So, Sampath, can I leave, Sampath, please?
Yes, madam. Thank you so
Thank
much,
you.
madam. Thank you.
हमारे यूपीसीओजी के 2 पल्स तो तुमने रोक लिए, भारती और प्रियंका, मैं अकेले जा पाऊंगी.
4:30, no? Yes, madam. Thank you so much.
very much. Thank you very much.
God bless. Thank you.
Thank you, ma'am. So moving on to the academic sessions, we have a very interesting talk on vaginal surgeries, tips and tricks. Sathi, can I have Archana Kumari ma'am CV? So to chair the session, I invite Professor Dr. Archana Kumari ma'am, who is the who's a professor and unit head at Ranchi. And ma'am is also the quiz committee chairperson, the founder secretary of IFS Jharkhand chapter, and executive council member of National ISOPAR. Welcome, ma'am. And I invite the speaker, Dr. Priyanka Garg, ma'am. Slides, please.
Yeah.
Yeah. Ma'am is a professor and HOD in Department of Obstetric and Gynecology at Ranchi.
This
and
is Dr. Archana Kumari. Sorry.
Yeah, okay, sorry.
Priyanka slide is
Priyanka
here.
Garg, ma'am. Yes. Ma'am is an 3D gynec endoscopic surgeon at Newtima Super Specialty Hospital at Meerut, and she's the pioneer of gynec endoscopy procedures in Meerut, and she's the first one to introduce 3D laparoscopy there, and she's also held numerous positions, and she's now currently the joint secretary and treasurer of UP chapter of obstetric and gynecology, and vice president of ISOPAR Meerut chapter, and also the Meerut chapter of IMS. And she holds the position of secretary of the Meerut Obstetric and Gynecological Society and North Zone coordinator for Spina Bifida Foundation. And she has numerous publications.
Thank you, Dr. Madhumita.
Won numerous
Good
awards.
enough,
We welcome you, ma'am. Such a
Yes,
pleasure to
okay.
have you here with us.
Good
Yes.
endoscopic surgeon.
Yes.
Thank you. And a good friend. I just remember the memories when we meet Sampath Kumari ma'am just now. Dr. Ajay Mane, when he was with us for North Zone UFAXI, Exer said ki we are like a family now. And it's so good to meet my family again. Thanks to this webinar for that. Yeah. So the topic, I could see that Sampath ma'am is talking about fibroids today. So what I thought is, if I cover whole of the vaginal surgeries, it could be a very vast topic. So I just curtailed myself to vaginal surgeries in fibroids, in larger fibroids, tips and tricks. So as we all know that the uterine leomyoma is the most common solid tumor in females. It consists of smooth muscle and fibrous connective tissue. It is a neoplastic single smooth muscle cell of the myometrium. It is of monoclonal origin. And we all know that now it was just hormones, but now we talk about chromosomal abnormalities and polypeptide growth factors as an etiology for fibroids. So we all know that predominantly it is an estrogen dependent tumor. But apart from that, it shows aromatase activity. So that is the fibroid itself converts estrone to estradiol, thus increasing the concentration of estrogen locally and causing endometrial hyperplasia, and is capable of growing in itself. That is why earlier it was thought that it is a reproductive age group tumor, but now it grows in menopausal females also, in those females who are very obese because they have high aromatase activity, which secretes a lot of estrogen, and that estrogen source is not from the ovary but from the fat and the fibroid itself. So, and now a lot has been talked about the progesterone receptors also, that the fibroids which have more of progesterone receptors, like in the breast, they are more likely to have leiomyosarcoma because they have a very high mitotic counts. So we all know that growth is by early menarche. So the types of fibroids, we all know intramural, submucous, subserosal. But location, originally, we were just talking of uterine fibroids. They can be fundal, anterior wall, posterior wall, lateral wall. But now there is an increase in incidence of the cervical myomas also. We see a lot of broad ligament fibroids. And even I did a case of ovarian fibroma, that is a fibroid stuck back to the ovary also. And with the advent of these morcellators and so many things, we now talk of peritoneal fibromatosis and parasitic fibroids also. So everybody, before embarking on any kind of surgeries in fibroid, should basically label the fibroids according to the FIGO classification. That is from class 0 to class 8. 0 is a pedunculated intracavitary fibroid. 1 is, most of it is in the cavity, but less than 50% is intramural. Then greater than 50% intramural is category 2. If it contacts the endometrium, but it is 100% intramural, then it is FIGO stage 3. 5 is when it has started developing a subserosal component, but most of it is intramural. 6 is less than 50% intramural, and 7 is the pedunculated subserosal ones. And there is a category which is category 8 for other fibroids, because now they are becoming commoner and commoner, the cervical ones and the parasitic ones. So fibroids can be single or they can occur in bunches. See, this is a lab video where we have one fibroid, and adjoining you'll be seeing a chain of fibroids arising from those. Then they can grow to enormous large sizes. We now see 32 weeks, 34 weeks, 36 weeks, very, very large fibroid, and multiple to the tune of around 100 fibroids in a uterus. Now, there are case reports where we talk about removing these 100, 125, as many. Plus, the concept of parasitic fibroids. What they do, they don't have the supply from the uterus. Like this is a fibroid. See, this is the uterus, but the fibroid is taking its supply from the omentum. It is not attached to the uterus down below. Whole of the supply chain is from the omentum, right? And the vascularity. It is very, very difficult to grade the vascularity of the fibroid. At times, they are very less fibroids. At times, they have a lot of vascularity. So all of us know that they are smooth muscle cell tumors. But what we should know importantly is the histopathology and the count of mitotic figures. Earlier, we thought that fibroids are usually benign. But now with the advance, there is an increase in incidence of leiomyosarcoma. So when doing a histopathology, the count of mitotic figures per 10 high power field is very, very important. And second then is the post-leuprolide or post-uric pristol effect. Initially, there is edema and necrosis, and then there is increase in the lymphocytic infiltrate, which is usually taken as maybe malignancy. We all know fibroids present with a variety of symptoms: asymptomatic vaginal bleeding, subfertility, pain, pressure, anemia. So whenever we are embarking on any surgery, whether laparoscopic, whether vaginal, whether abdominal, it is very, very important to do a good clinical assessment and investigations. So the gold standard is a pelvic sonography, which is both abdominal and vaginal. So fibroids are usually seen as a distinct entity in the vaginal sonography. But the limitation is that usually it might miss the submucosal fibroids. So if we are versed with the technique using saline infusion sonography along with the fibroid, instilling saline can delineate the submucosal fibroids, or you can directly go for a diagnostic hysteroscopy before you plan any kind of surgery for fibroid.
Hello,
Because
namaste.
you can see
Good evening,
this
everyone.
in the, it is, Bharti ma'am, can you please mute yourself?
Please,
Bharti? Yeah. So, okay. So these submucosal fibroids are clearly seen. And a very important investigation which has come forward is the MRI. But MRI is not required in all the cases. Where do we need it? Why is MRI good? Because it gives an accurate assessment. It is not technique dependent. It has low inter-observer variation, and it can also tell the impact of fibroid on surrounding organs. But, and above all, it delineates a fibroid from adenomyoma very clearly. See, this is a myomectomy just to show that a fibroid has a pseudocapsule. Okay, this is the pseudocapsule. Whole of the vascularity runs outside this pseudocapsule. So a myomectomy is a very easy and a rewarding surgery. But in cases of adenomyoma, the adenomyoma develops from the uterine torus. So the adenomyoma in the same location is usually adhered to the bowel, to the ureter, and it is a difficult technique. Plus, adenomyomas should be managed earlier medically and then only embarking onto the surgery. So, myoma versus adenomyoma should never come to us as a surgical surprise. It should be diagnosed pre-operatively so that the patient can be counseled accordingly. So any investigation, USG, MRI, hysteroscopy, or even a laparoscopy can be done. Now, a very important component of decision of delivering the fibroids vaginally is the type of degeneration in the fibroid. Usually, fibroids are muscular kind of tumors with very less amount of fibrosis. But at times, fibroids present with calcific degeneration, so much so that they can be seen as calcified stones, large stones in the X-ray pictures. So it is very difficult to actually retrieve these calcified fibroids vaginally. We break so many knives. At times we have to use our bone nibblers also. Another one, the apex is calcified degeneration, but the most softer component is the cystic degeneration. So see, in cystic degeneration, whenever we are operating, whenever a myomectomy is proceeded, it is difficult to delineate the myometrium and the other muscular tissue from the cystic degenerated fibroid. See, the uterus has become so soft, and the fibroid has undergone a lot of cystic degeneration. Can you see? The fibroid, which is caught hold by the Alice forceps, is actually now almost a cyst. And these fibroids, I see what we did was, this was a large 10 centimeter fibroid in which the patient presented to us for a redo surgery with a lot of bleeding. So the challenge was to save the endometrium in such a case. So we removed all of these fibroid. Now with the good 3D endoscopy, you can see the endometrium different and a delineation between the fibroid and the endometrium. But again, when I was retrieving this specimen vaginally, again, it is a difficult task because this specimen keeps on breaking. So like in larger fibroid, you can make a larger pull. But for these specimens, you need to be very, very soft, holding them and then removing a whole lot of them. Then nowadays, we see a lot of red degeneration in pregnancies also, because the fibroids now present in early age group, and larger of these females are getting pregnant with fibroids. So another important consideration is the sarcomatous changes. Usually earlier it was described that this occurs in less than 0.1%, but now the incidence is rising to around 1% also. So when do we have a high suspicion, when there is a recurrence of a fibroid polyp, sudden enlargement of fibroid, then pain and bleeding, and the fibroid is closer to menopause. Two investigations which help are a serum LDH level and a GD, that is gadolinium enhanced MRI, where you can see the increased vascularity and perfusion. So why now vaginal myomectomies in cases of fibroids? Earlier we were very happy morcellating, but please keep quiet, morcellating all these fibroids. But now we all know that uncontained power morcellation is strongly condemned. But scalpel morcellation, which we do vaginally, appears to be a safer choice. So this is just a small video how we put the fibroid in the more safe endo bag and then retrieve. But whenever we are putting in the bag, we don't have a supporting force. So morcellation in the endo bag takes a lot of time. So my dear friends, again coming back to the vaginal approach. So now we should know how to remove larger specimens vaginally. Whether we are doing a vaginal hysterectomy or a laparoscopic hysterectomy, the specimen removal vaginally is very, very important. And now they are also talking of, because the problem is not just about malignancy, the problem is about having small parasitic fibroids. So again, putting them in the endo bag and doing contained morcellation vaginally is also important. See, this is how we do it vaginally. We are not hastening to remove this fibroid, this uterus. We have taken the uterine arteries. We are just waiting for the whole specimen to come out. We can core, we can bisect, and this is how we put the fibroid into the endo bag. We can use a simple Euro bag, and with this endo bag taken out vaginally, spreading this endo bag vaginally, we then remove the specimen vaginally so that endometriosis, adenomyosis, fibroids, then ovarian cysts, they do not spread out, right? So whatever we'll be doing in this endo bag. So morcellation. Another important thing is using the pouch of Douglas. Usha Sharma ma'am has left, but earlier, before laparoscopic tubal ligations, we started with vaginal tubal ligations. So colpotomy appears to be a safe and effective technique in removing the fibroids vaginally. See, this is a video in which we actually removed very large fibroid vaginally. See, just a bit of patience with the specimen retrieval, and this is all done through the colpotomy. We are not, the cervix is high above, and with the colpotomy, making a U-shaped colpotomy, just learning the tips and tricks. Do not try to pull it out. Just try to core the specimen, make it like the fetal head. The fetal head, if it is in the transverse diameters, it is difficult to deliver it vaginally. But once it rotates well, then it is easier to retrieve it vaginally. So we need to learn colpotomy and other maneuvers which actually are difficult to be done vaginally are the laparoscopic uterine artery occlusion. That means if we are doing vaginal hysterectomy for a very, very large fibroid, again, you can do laparoscopic internal iliac artery or a laparoscopic uterine artery occlusion at the origin. See, this is a video in which it is a normal sized uterus. We are just doing Lowell for a large AV malformation. We usually take the anterior approach. This is the external iliac. Now you can see this is the ureter moving. Once the ureter, then between the ureter and between the external iliac, we go deep down to expose the internal iliac artery and the origin of uterine artery. But with large fibroids who are transversely enlarged. As seen in this video, it is very difficult to do the anterior approach. So we usually resort to the posterior approach because this fibroid can be taken up anteriorly and at the bifurcation of common iliac artery, where the ureter crosses the common iliac artery, we start dissecting, then delineate the ureter, take the ureter medially, and then have a look at the internal iliac artery. So everybody should know this art. See the ureter, because I am using the green dye. We can see the ureter green. See, this is the ureter. The ureter has to go medially. Okay, this is onto the right side. So ureter medially, then external iliac deep down. You'll be able to see the internal iliac and will be able to clip it. Right? See, this is the internal iliac coming up. Then from the internal iliac, we will see how easily, without doing anything, we are able to dissect it with simple instruments. And we need to, all should learn how to devascularize the uterus. We can use a temporarily shoelace technique or can clip it also, right? So management will be discussed in detail in the next panel discussion. We know where there are various medical options. Then we have the non-surgical maneuvers like uterine artery embolization, fibroid ablation. Then last resort is hysterectomy, myomectomy. So LNG also to relieve the symptoms. Then vaginal hysterectomy is the preferred technique. It provides several statistically significant advantages: decreased blood loss, shorter hospitalization, shorter paralytic ileus time. But it is limited by the size of myomatous uterus, and we need to learn this technique. Either we do a TLH in a large fibroid, again it is difficult, then remove the specimen vaginally, or we clip the loal. That is also a difficult technique to learn, then do it vaginally. But laparoscopy and vaginal surgeries in cases of fibroids go hand in hand. So we should think twice before doing an open surgery. Again, in laparoscopic hysterectomy, because of the limitations of the use of power morcellation nowadays, the technique has become under scrutiny, and then we are resorting to removal the specimens vaginally. Again, the same thing in myomectomies also, we are more and more now using the pouch of Douglas to remove the specimens vaginally. And hysteroscopy again remains the gold standard. So if hysteroscopic myomectomy is possible, this is the preferred approach. If not, then we need to, if the woman is greater than 48 years old, then medical management, she might approach menopause. But if she's less than 44 years old, large fibroids, asymptomatic, we need to go for hysterectomy. But if she desires future first fertility, then again, if hysteroscopic myomectomy for submucosal, for intramural, you try medical management first, and then you start doing laparoscopic myomectomy. But you need to know how to retrieve the specimen, either by contained morcellation or by a vaginal pouch of Douglas. Then again in the future, you need to follow all these patients for assessing the growth, because hysterectomy is the ultimate solution. And once she completes her family childbearing, either you put in a Mirana, go for a Loal so that the blood supply of the uterus is decreased, or you go for an hysterectomy in all these cases. Another challenging situation, I've done many cervical fibroids now, is the cervical fibroid. All of us know that it is like a lantern on the St. Paul's Cathedral, but it is a trouble doing laparoscopically also, because the uterus sits on the top of fibroid, and what to talk of vaginally, because a vaginal surgeon approaches everything vaginally, and the fibroid has its supply from the uterine artery, which is above, so it is difficult. Again, we need to learn the laparoscopy and vaginal approach combined. We need to be good surgeons and not just vaginal or lap surgeons. So the learning curve of laparoscopic or robotic hysterectomy or myomectomy or surgeries goes through a good vaginal surgeon. Yes. So there is a paucity of smooth muscles. So that is why they are difficult. So just to summarize, fibroid management is an increasing dilemma and enigma. And it is like a Google map. We need to map it, try the shortest route, try the best route, try the least vascular route. Using vaginal approach for hysterectomies, specimen retrieval for lap hysterectomies, retrieval of large fibroids through cul-de-sac when resorting to myomectomy are safe approaches, especially when power morcellation is condemned. Tackling the blood supply or tackling the uterines is the trickiest part of the surgery. Larger fibroids are challenging, but it provides immense satisfaction once the specimen is retrieved stitchlessly. So this is a specimen of a large 8 kg fibroid which we removed. The patient was emaciated. Itni patli, we thought it to be a large malignant ovarian mass, and to our surprise, it was a fibroid. So hard work, dedication, they don't have any substitutes. There is a learning curve to any minimal excess surgery, and we all need to go through it. So these are my good memories with Sampath ma'am. Recently, the darshan of Anganath Mandir, which is a famous place at Meerut. Ajay Mane sir, Rajendra Pardesi sir, all of us with us. And Dr. Archana Kumari, I don't think
She didn't join, I think.
she's there. She's a very good friend from Ranchi. We have, yeah. Thank you. Thank you for a patient hearing. And now we'll be tackling our brains all the more as we go through the panel discussion of managing fibroids from birth to menopause, I think now. Thank you. Thank you, ma'am.
Wonderful talk, Priyanka. You have covered everything. Really, with the videos and within the short duration, you have covered. Fantastic. Thank you. Thank you so much. I told her only 1 week back earlier, I think. Immediately she accepted because I was roaming it. Anyway, thank you, Priyanka. Fantastic. And again, thanks for the blessings going to the temple and had a wonderful darshan.
Thank you, ma'am.
Thank you, Priyanka. Now we will go with the panel. Bharti madam is here. Dr. Bharti, instead of Dr. Radha Madhavi, Dr. Priya Kannappan will join. She is having some emergency. Bharti, you have to mute.
Bharti ma'am, you're muted, ma'am. Yes, ma'am.
Madhumita,
So, yes, ma'am. Yes,
Bharti
ma'am.
madam and the other panelist.
Yes, ma'am.
Now,
So,
I think all of you can hear me.
Moving to the
Can
end
you
of
hear
this.
me?
Yes, ma'am. We are able to hear you, ma'am.
Okay,
Yes, ma'am.
okay,
Okay.
okay.
So after the wonderful talk by Priyanka ma'am, we move to the next awaited session. That is the panel discussion on case scenarios on fibroids. So for the as an expert in the panel, we have our Professor Dr. Sampath Kumari ma'am, and to moderate the panel, I invite Dr. Bharti Maheshwari ma'am. Ma'am is a professor in HOD, HOD of Obstetric and Gynecology, and ma'am is also, she was a past chairperson of Foxy MTP committee and a governing council member of ICOG, and also the secretary of UP COG and president of Meerut Obstetric and Gynecological Society, and also president of Meerut Isopar and Meerut Menopause Society. It's a pleasure to have you with us today, ma'am. And I invite our panelists. Sati, slides, please. Yeah. Dr. Gomati, who's the assistant professor at currently at Mada Medical College at Kundratur. Next, please. Dr. Sadhana Devi, who's the consultant obstetric and gynecology and fertility specialist at Yogesh Fertility Women's and Urology Hospital at Chennai. Next, we have Dr. Priya Kannappan ma'am, who's the South Zone Coordinator of Quiz Committee and also consultant obstetric gynecology and fertility in Chennai. Dr. Radhika Gauri, who's currently the consultant at ESIC Hospital at Tirunelveli. And next we have Dr. Rupali Gaikwad and with us, and Dr. Suresh Raute, who is a professor of OG at Aurangabad, Maharashtra. Over to you, Bharti ma'am.
So good evening, everyone. And I hope that all of you can hear me.
Bharti,
So,
Madhumita, how many of them have joined? All of them are there. Madhumita, call Dr. Sardana. Bharti should know who are all.
Sadhana ma'am is here.
Madam
Priya
is there.
Kanappan ma'am is here.
Gomati is
Gomati ma'am is there, ma'am. 3 of them are there.
Priya Kanappan is
Dr.
there.
Sadhana Devi is here. Dr.
Gomati is there.
all of
Dr.
you,
Priya
please
Kanappan.
rename yourself, those who are by doctors only.
Dr.
Dr.
Gomati, Dr.
Gomati, I
Sadhana
can
Devi,
see.
and Dr. Priya Kanappan. 3 of them are there, ma'am.
Dr.
I'll just
Priya,
call Dr.
how are you,
Doctor.
Dr. Priya?
Actually, Dr.
And there are few doctor, 3 people have named only doctor. I think they
Doctor.
may also be the panelist.
Actually, Dr.
Yeah,
Suresh had joined actually initially, ma'am. I think sir has left.
Sorry, his name. Dr. Suresh, are you there?
If you
He
can
was-
Please open your video. We can see you even if your name is not there.
Then Bharti, you start with our 3 people.
Yeah, sure, no issue.
I'll call the
So,
others, ma'am.
So, first of all, Dr. Sampath Kumari Madam, as we all know that you are so academic and so humble and approachable, and you have kept with this webinar with the Merit Society and others, and you have chosen the topic fibroid. So, I thought though the fibroid seems a very common topic, but there are many issues that is we have to update because every patient is different, and Dr. Priyanka has given a very informative lecture on the fibroid and shows the video also. So nowadays we have lots of advancement in the management of fibroid. So in the next 35 minutes or 45 minutes, we will see what we can do. So we have an expert, Dr. Sampath Kumari, and all panelists, which is already introduced. So we all know that fibroid are hormone-dependent progesterone driven which are dependent issue, and most common benign pelvic tumor of a smooth muscle tumor with fibrous connective tissue. Most common cause of actually cystectomy worldwide, and also known as leiomyoma, myoma, fibroid, and it can occur at any age. So Dr. Sampath Madam has given me that please issue at every age the 4 important questions. So though it at young age rare, but of course it is it can be there, and reproductive age is the most prevalent vena fertility and bleeding issues. Perimenopause symptomatic but may regress with menopause. Post-menopause regression expected growth suggests malignancy. So age-wise distribution of fibroid, if you will see, then the maximum 27% cases 35 to 39, as well as followed by 40 to 44 year of age, and of course 20 to 24 age it is less around 1 to 3 or 4%. So now we come to the case wise, and after every case, Dr. Sampath Madam can give take home message. So first case anyone can take you. A 16-year-old girl come to OPD with complaint of heavy menstrual bleeding. For 6 months, dysmenorrhea, lower abdominal pain noticed by the patient. History of present illness, you take menarche at 13 years, cycle regular, progressively heavy, no family history of fibroid, no other comorbidities. Investigations, hemoglobin, you do that patient is having history of anorexia, 0.5 hemoglobin. Ultrasound, when you do, because in such cases, always we think that menstrual irregularities could be there at the 16-year-old, but on the ultrasound, you find out the unexpectedly large intramural fibrate 9 to 11 centimeter, which is arising from the anterior abdominal wall. So, of course, then as I have already discussed, in less than 20 years, it is a rare occurrence. When present, usually single large symptomatic may cause heavy menstrual bleeding, severe dysmenorrhea, pelvic mass symptom, negative genetic proposition. So, any panelist, I just want to know that in this adolescent, that it is a rare. So, what is the common possibilities or etiology of fibroids in adolescents, and what should be the approach or option for management of fibroids? Anyone? Dr. Shanta,
Dr. Priya is that. Priya, you can take up the question, no?
yeah.
Yes. So usually whenever it occurs very early, we are thinking of genetic predisposition. So definitely most of them will have a family history that the mother or the relative are also having a fibroid. So, but I don't think we are going and checking on these chromosomal abnormalities, though they have been there. And I mean, if they are on the heavier side of the weight, then you're going to think of obesity leading into hyperandrogenism, or if they have a occult PCOS and that is giving a increased estrogen, and that can be the reason. So that are the things which you're going to think of. And for this patient, initially, if she's come to us, yes, definitely. So as I told you, for environment, we are going to give her a lifestyle advice, definitely that is there. And other than that, for management, I will treat her symptomatically, madam. For the time being, I will just give her at least a tranexamic acid to start with for heavy menstrual bleed. And for the pain, I will give her an NSAIDs. And if she's okay with the conservative or the symptomatic management, then I think I will just continue with those alone for the time being. First start.
So, true, doctor. So here I want to highlight that in the adolescents also fibroid can be present there, and it could be because of either genetics or hormonal influence, or growth factors and molecular pathways are also suggested when there is increased expression of growth factors, transforming growth factor B, epidermal growth factor, insulin-like growth factor, and this stimulates proliferation of smooth muscle cells, as well as of course nowadays environmental factors where it can be we can interfere, that is like obesity and vitamin D deficiency, etc. Other associated conditions with the fibroids are also seen like PCOS and rarely associated with Reed syndrome. Whether it's a hereditary syndrome, there is a leiomyomatrix and a renal cell carcinoma. So PCOS and other hyperestrogenic states. So whenever the fibroid is there, we should take care of all hyperestrogenic states, and the higher estrogen and progesterone receptors are found in fibroid. And progesterone is the main hormone causing fibroid growth. So exogenous hormones like COCs and IMPA, they are not shown to increase fibroid growth and may have a protective effect. So these factors already you have told, with increasing age, chances of developing fibroid increases, early menarche and late menopause. That is also causes increased chances of fibroids, obesity, hypertension, sedentary lifestyle. They all cause increased risk of fibroid, vitamin D deficiency, and high dietary fat intake also. So management, as doctor you have told, if we talk management depends on the size of fibroid, location of fibroid, clinical symptoms and all. As Dr. Priyanka has told, there are many management options, and as you have told that the symptomatic treatment, NSAIDs, tranexamic acid and COCs, progesterone only pills, GnRH analogs, they can be given according to the need. In this particular patient, as fibroid is 7 centimeter size, so of course myomectomy is required, and laparoscopic myomectomy oblique open myomectomy. So any panelist you want to take that in this particular case, what myomectomy is preferred and why, and what are the advantages or disadvantages of these things? Anyone want to take?
Dr. Komati,
Yes, ma'am.
so which type of
You want to comment which route of myomectomy you can do, both or any
Hello?
preferable?
Yes, we can hear Komati.
Hello, ma'am.
Yeah.
Audible, ma'am.
Audible, Komati, you can talk. Hello, Komati.
Hello.
You are audible.
Not
I
correct.
think she is not
Madam?
able to speak.
Not
That
audible,
is
ma'am.
why she's not
Network
speaking.
is not rare because she can't hear us.
Madam, can you hear me?
Yeah, yes. We can hear you.
Can you hear me, ma'am?
Yes.
Sadhana,
No,
you
she
could-
can't hear us, I think.
Shall I?
Yes,
Yes,
Sadhana.
Sadhana.
This patient being an unmarried girl, young girl, the choice would usually depends upon choice is usually a laparoscopic myomectomy,
Hello?
but it really hello. Yes, am I audible?
Yes,
Yes,
Sadhana,
You are
can
audible,
hear.
ma'am.
So laparoscopic myomectomy would be the choice for this girl, as she's a young female, about 16 years old, and the fibroid is huge fibroid, more than 8 centimeters. And the skill of the laparoscopic surgeon also do matters. And regarding the port placement, it should be the trocar placement should be not over the it should be well ahead of the port placement should be well above the fibroids, and a laparoscopic myomectomy would be the choice.
Yes. Dr. Suresh is there. Do you want to have the opinion, Dr. Bharati?
Yeah.
Dr.
So
Suresh?
anyone want to add something about that? Which route of myomectomy is preferable, or anyone can be done? It depends on what factors.
I think only this two are there. Suresh, I don't know what happened. The Komati is now she is not able to hear. Is it
Yeah,
late?
ma'am.
Dr.
Personally, I
Suresh
feel
is
an
there.
laparoscopic route shall have some advantage over this open route at this phase, as the laparoscopic expertise are also improving. So we are having a lot of advantages over this open surgery. Laparoscopic myomectomy is supposed to have less blood loss as compared to the open one.
See, I
Okay.
just want to add something. Okay, laparoscopy is the gold standard, but the basic thing is how you tackle the fibroid, like placing the incision. Like earlier, for very large fibroids, we were talking about the circumferential incisions. It is not that open our lab, okay, any route. The issue was that a lot of myometrial tissue was also being hammered. So they always, now there are two schools of thought, whether a single transverse or a vertical incision over the fibroid, then approximating or a circumferential, because it is easier to do circumferentially. Second is suturing. That is very important. What type of suture should be used? Earlier we were using Vicryl as the delayed absorbable suture, but with the Vicryl, the tensile strength doesn't go uniformly because that scar has to undergo pregnancy later on. So nowadays we are now using those barbed sutures. So we have delayed absorbable barbed sutures. So the double barbed, single barbed. The problem, like the advantage is that once you pull them up, the tension along the suture line will be smoother. Third is serosa. So one is you have to save the endometrium. So whenever what route you are doing a myomectomy, the endometrium should be spared
So here
so
I
that the
want to add.
cavity is not distorted. Second is
So
even
Priyanka,
serosa also, ma'am. I'll just finish. Ji, Didi. Yeah.
Yes.
I think Bharti ma'am wants to add something.
so like Priyanka, you have told in your lecture also about the issues related to laparoscopic myomectomy. So with the all audiences, I just want to share that recent update is that of course adolescent girls 8 centimeter fibroid. If one can do, one is expertise, one has facilities, one can do the laparoscopic, of course, laparoscopic myomectomy. And but again, whenever either you do open lap myomectomy or laparoscopic myomectomy, always the issue was how to achieve the hemostasis. One thing, and it can be either by the uterine artery ligation prior, or by the vasopressin, or by the barb sutures. What you have done, these things have to be taken care. Second thing, the preference is that the incision that it should be like that all fibroids, if they are one, then more than one, they should be taken care of by one incision, and posteriorly incision should be avoided, because as the girl is young, so we should try that she should not have fertility issues and she should not have additions. And second thing is that before taking the patient for surgery, by the proper transvaginal sonography, we should do the proper mapping, that sometimes that only one fibroid, sometimes others multiple fibroids can also be there. So that proper mapping, proper location, number of fibroids, then mode of operations, then if you are doing either by open or either by lapro, then the incisions, location of incisions, and then proper hemostasis achieved, proper informed consent. Patient should be informed all consequences and all about the thing that myomectomy, the bleeding blood loss as well as recurrences, they should be told, and then the proper safe surgery should be done. So of course in this particular patient 8 centimeters, so laparoscopic or open surgery is advisable to remove the fibroid. Then next question to any panelist, that once the patient we have removed, and if this patient was unmarried, then it's okay. So what precautions or what advice and any counseling we should do, that if patient marries then after myomectomy, or even if she is married and her surgery is done, then after what time she can conceive, and what is the recommendation for her?
Dr. Gomati, are you now able to talk? Gomati?
Yeah.
No.
Anyone can talk. Dr. Gomati, you are there?
No,
Yes, ma'am.
Yeah,
yes,
please. Post-operative care and
So,
counseling.
So when a patient is going for laparoscopic myomectomy, the risk of scar should be, she should be careful for that scar preparedness, ma'am. So she has to be postponing the pregnancy for minimum of 4 to 6 months and close follow-up, ma'am.
Yeah, so what I got update that if a woman is in the fertility zone and she wants to conceive, so after myomectomy, she should try after 6 months at least, and then of course proper care of uterine scar should be done. So that was about the myomectomies in the big size of fibroid, and when we have to do lapro or open myomectomy as patient is young. Now, the another case scenario where the 28-year-old woman come OPD with chief complaint of primary infertility for 3 years and heavy menstrual bleeding, dysmenorrhea, menstrual dysmenorrhea for last 2 year regular bleeding 7 to 8 days with passages of clot, and blood test में hemoglobin is 8.9, so she is having the irregular bleedings and heavy bleedings for last 2 years on and off. Ultrasound multiple intramural fibroids. The largest is 6 centimeter in posterior wall. Another 4 centimeter submucosal fibroid distorting the cavity. So one is the intramural 6 centimeter in posterior wall, and another is the in the 4 centimeter submucosal fibre distorting the cavity. On HSC, distorted endometrial cavity tubes are patent. Hormone profile is normal. So how these fibroids should be approached, and what is the counseling for these patients for the fertility, and what other things should be taken care of? So Dr. Radha Madevi Davi may have, or Tanda Devi
Yes,
madam?
madam. Dr. Radha
Yeah,
Ma'am
please.
is there, so I'll take the question. So definitely every submucous fibroid for a patient who's trying for fertility has to be removed, even though the size can be small, large, because whenever you think that the fertility is the concern, then definitely each submucous fibroid, at least whoever is measuring more than 1 centimeter, have to be taken out. So that is no question at all in that. And intramural fibroid, usually the size between 4 and 6 are little dilemma. We don't, I mean, like, some people operate at 4, some people say at 6, but anything more than 6, most of us will agree that we'll go ahead and operate even if it is intramural, because we think that the uterine contractility can be increased and it can cause the embryo expulsion or the sperms also to be pushed down. So we relate the cause for that. But the subserosal, whatever the size is there, it has not been totally linked to fertility. Till now, I mean, like, I'm not aware of any studies which says that fertility can be caused by subserosal. So whatever the size of subserosal, I don't operate on the subserosal fibroids, madam. I mean, unless and until they're very large discomfort for the patient, say some 20-week size fibroid, a 15 centimeter sitting on there, and she's having a discomfort, then okay. Other than that, no.
Nice.
Yes,
Sorry,
so we
ma'am.
all know. Yeah, anyone want to add something? Dr. Suresh, sir, regarding the infertility, what counselings and what are we have to taken care of when we have multiple fibroids?
Multiple fibroids can cause
Madam, we have to
hormonal block.
uh, convey the positive message that removing the submucosal fibroids and the big fibroids are going to improve the possibility of the pregnancy and as well as the pregnancy outcome. So there should be a positive counseling regarding that.
Yes, so we should understand that what type of fibroids and how it affects the fertility. Maximum infertility is affected by submucosal followed by intramural, and in the last subserosal. If fibroid subserosal is there, then we are not much worried. But again, the fibroids affect only 5 to 10% of infertility cases having the infertility because of fibroid, what the study says, and 1 to 2.4% of infertility cases they involve fibroids. Where the infertility is only due to fibroids. So of course it can affect implantations or block fallopian tubes and can and alter the cervical shapes and cervical fibroid is there. Disrupt uterine contraction as well as blood flow can be disrupted. So in this particular case, when there is a one submucous fibroid, when there is a one intramural fibroid, so what should be the mode of removal of fibroid? Anyone want to take this case? Those who do for any surgery, laparoscopy, hysteroscopy, or you will do it openly, then how you will remove fibroid? I am
This
trying to move my
laparoscopy
slide.
will be a much better option when we consider a 4 centimeter fibroid, because it's going to be difficult to do in a hysteroscopy as a single sitting. So it is like, anything more than 4, I mean, like, even around 4, it's going to be a big size to remove it hysteroscopically. And especially when you have multiple other fibroids as well, and then you have a 6 centimeter intramural. So I think when one go, whichever fibroid we can approach, so we are going to remove all the fibroids. So preferably put an incision so that you don't make multiple incisions on the uterus. So through that, you try to negotiate and take out at least, one on the anterior wall and one on the posterior wall, and try to get all the fibroids to the same incision so that there are not multiple incisions over the uterine surface.
Right.
Dr. Sampat Kumari, madam, as expert, what you want to add that in these particular two cases?
No, as Priya and Suresh sir was telling, it is better to go with a single incision and remove all the fibroids as far as possible. Because she is a case of infertility, no? Suppose if she, even the adolescent or not delivered means, always it is better to have a single incision over the uterus. That will be the convenient. And for medical management, since here there is a multiple fibroids, there is no possibility. I think it may not be successful. Even since the complaint is of infertility, it is better to remove the fibroids as much as possible. That is my opinion also, Bharti.
Yes. So actually मेरा थोड़ा सा ये प्रॉब्लम था अभी हैंग हो गया था. Now I think it's okay. Can you see my slide?
Yes, you go to the slide.
Yes. I am going to the next.
Slideshow.
It is not moving. I'm seeing the next.
Now in the bottom you will.
Okay, I do. So what is the role of non-surgical management of fibroid in patient with infertility? And what are the novel methods of treatment of fibroids in cases of infertility? These two are important questions. Yes, infertility in fibroids. So all of you have told that you will do the proper initial assessment, you will do the detailed infertility workout as well as pelvic ultrasound. That is very important because a good pelvic ultrasound can tell you all number of fibroids, and mapping they can do very good. Though sometimes MRI is needed, but even if TVS can do this, determine whether fibroid is causative for infertility or not. Then expectant or conservative measures if they are not distorting uterine cavity. But in this particular case, it is distorting the uterine cavity. Of course, cervical fibroids you have to remove. We can do in this cases hysteroscopically. And medical management, sometimes it is required before removing the fibroid hysteroscopically, either by the GnRH agonist or antagonist or uniprostol acetate. Now the management, which is the novel method of treatment of fibroids in infertility, what I have got, that MRGFUS, that is actually reveal equivalent recuperative outcome, but it is not very much recommended. These studies are going on. And what is the non-surgical management? So, madam, in this particular case, of course, surgery has to be done. Priyanka, are you there? So, of course, we have to remove the fibroid submucous hysteroscopically, and we have posterior wall fibroid, so we have to do it either by openly or by the laparoscopically. So we can do both fibroids removal also by the open methods or by the laparoscopically. So what does role MRI play in the pre-surgical mapping of fibroid for fertility preserving surgery? Of course, we all know MRI is recommended for assessing vascularity and differentiating fibroid from other pelvic mass. For only mapping can be done by the good ultrasound and MRI also both. So subfertility indications, symptomatic fibroid, heavy bleedings, and couple presenting with multiple failed cycle of ART. And she is having the intramural fibroids, and definitely myomectomy is recommended. Infertile women, those women undergoing ART procedure who have demonstrated some mucous fibroids, preferably that are also removed. So hysteroscopic myomectomy as well as laparoscopic myomectomy, I think this is done very well in the lecture by the Priyanka. So now the comes what is not recommended in infertility. So actually in cases of infertility, subserosal fibroids usually do not require removal unless they are large. Uterine artery embolization, fertility outcome, poor risk of uterine ischemia. So when it is compared with the embolization with removal of fibroid when there is a distortion of cavity, so removal of fibroid is preferred, and hysterectomy not for women desiring pregnancy. If we talk about the ART, if infertility persists after myomectomy or other factor coexist, then of course IUI or IVF may be used. Myomectomy before IVF improve implantation in cases with some mucosal or large intramural fibroid. So this was all about the fibroids and infertility. So anyone wants to add something, please you can before proceeding to the next thing.
Dr. Sadhana?
Yeah, madam, Sampath madam.
No, everything you had told, I thought whether Sadhana was there, whether she wants to add anything. On the case which you have presented only surgery. Sadhana?
Madam, previous case, ma'am. Case 1 and case 2.
Case 2.
So case 2, we would add to, since the woman is infertile, the choice would be a laparoscopic myomectomy, as you said, and plan for her conception, ma'am. So in after 6 months, actually, you can give there should be a gap of about 6 months after surgery, and this women can plan for conception now. So even after 1 year of this thing, if she doesn't conceive, we can go in for ovulation inducing, and other methods can be opted for her.
Yes, so for the first case and second case, as per the panelist also, the surgery is the treatment. Yes, Bharti, you can go with the third case.
Then we come to the next case. That is a perimenopausal woman, 40-year-old female with para-2 life to come to OPD. She complained of heavy menstrual bleeding for the past 1 to 2 years, dysmenorrhea, abdominal lump, fullness notice for last 6 months, pressure symptoms like frequency, constipation, backache. And history may you take intermenstrual, no history of postcoital bleeding on intermenstrual bleeding. And when you do the investigation, then on the ultrasound pelvis, you found that there is a large uterus with multiple intramural and subserosal fibroids. Largest is a 6 to 7 centimeter MRI pelvis mapping of fibroid relationship to endometrium, myometrium, intestine, 8.5 gram hemoglobin. So when in these cases we have done the MRI, so is it required in such cases, and what is the advantage of MRI? And second thing is there is a role of any Doppler in diagnosing the characteristic of fibroids? This was the second, and how asymptomatic fibroid should be managed in cases of 40 years. In this particular case, he is symptomatic. So these are the questions, the role of MRI, color Doppler. Anyone?
So usually, ma'am, whenever you consider of MRI or ultrasound, whatever be the good quality, when there are multiple fibroids, the scan doesn't give you such information. And sometimes the uterus position can be retroverted, retroflexed. That will be very difficult even with the TBS to get the uterus because it may be very high up. And when you have very bigger sizes, they'll fall like shadowing will be there. And especially when they're long standing, you'll even have calcific spots. And those periods, definitely your TBS will be a little confusing. And when your uterus size is very big, then obviously your ovaries, it just pulled up into the abdomen. So if a patient is thin size patient, then yes, your TAS will give you the multiple information, yes. But if the patient is obesity, especially we have all the women have abdominal obesity. They may be overall weight can be in the normal range or a little overweight, but they have too much of abdominal fat. In those patients, even with the TAS, you don't get much information on the adnexa. Sometimes we go in and have surprises when we go inside that there's a adnexal cyst which is sitting there. So in those cases, whenever there's a large multiple fibroid, definitely your MRI has a role. That is one. Second thing is Dopplers definitely have a role because one, when you're thinking in terms of sarcoma. So if you are having a suspicion that whenever you have large fibroids, especially in the perimenopausal age group, there can be an associated sarcoma component there. So your Dopplers, if there is highly vascular, you have to suspect that. And MRI will definitely differentiate between a benign and a suspicious fibroid. Sometimes even when the MRI gives us a sarcoma, when we do the histopathology, it can still be benign. But at least we have a suspicion because that helps us in the counseling part of the patient. And you involve an onco-surgeon beforehand so that, we are safe as per the law and we are not got into litigation of missing a malignancy. And definitely will not be using a morcellator in case if they give us already a high suspicion of sarcoma.
True.
Can I add on, ma'am?
Please.
Yes, ma'am. This female is 40 years above, ma'am, actually. So MRI now, as per actually now comparing this MRI and 3D ultrasound, 3D, 4D ultrasound nowadays are more sensitive for mapping. So it is similar to actually MRI. A highly experienced person in 3D and 4D will definitely tell you the size, mapping, exact location, everything. And as far as sarcoma is considered, we can consider the vascularity. And apart from that, LDH will add on to it. So if we have previous ultrasounds and comparing it, if the size increases, if the size doubles or something like that, a short span about 6 months, we can consider about sarcomatous changes. And for that, LDH would be a marker for that. And apart from that, Doppler, using Doppler indices, if the vascularity is so much increased, then we can plan priorly. And the patient can also be counseled prior to surgery. And of course, in that time, we don't do a laparoscopic approach, we do a laparotomy. And as usual, we can do, intraoperatively, we can go in for even looking for a frozen section, and we can, planning can be done priorly. An onco surgeon in hand.
Madam, if this patient, as she is having actual heavy bleeding in the 40 years old, but like some patients come with abdominal pain and she's not having heavy bleeding, or we do ultrasound for just on and off mild pain, and we find accidentally some multiple intramural and small fibroids or subserosis. So what treatment we should recommend, or what are the treatment options, and what are the consequences of these treatments? Can we manage patient expectantly, or if yes, then how, and or we should do surgeries on this?
Asymptomatic.
Yes,
Can
sir.
I, ma'am? Asymptomatic fibroids needs no intervention, ma'am. Actually, the patient can be reassured. We can counsel her, and we can really send her off. And the serial ultrasound monitoring can be done as early.
Sadhana, madam, even if any size of fibroids, we can
Yes,
leave
of
it.
course.
We can
Of
leave.
course, ma'am. Any size of fibroid, if it is asymptomatic.
If it's a large fibroid, we call
More
them
than
follow-up. We call them for follow-up. We just, like it can still be a sarcoma, which can be asymptomatic also.
Yes,
So
we can actually we can counsel her, and it can be monitored with serial ultrasounds. And of course, nowadays we have 3D, 4D also to look into the vascularity. Everything can be added on to it. And as for now in Chennai, we have so many so good centers where even the ultrasounds they do a better ultrasound is better compared to MRI. And this patient being asymptomatic, we can manage her. She can be given. Surgical management can be deferred for this patient.
So follow-up strategy, you have told that even if patient is not symptomatic, her family is completed and she is very menopausal, or whatever is more than 40, then we can manage it expectantly. But again, we have to tell her follow-up strategy. We have to keep patient. Recommended intervals include 6 months for initial assessment, extending to 1 year if no growth is detected. So we have to follow the fibroid, whether it is increasing, and we should remain aware. For the postmenopausal, if fibroid remains stable for a year, they don't need further monitoring, or sometimes sarcomatous changes or degenerations are there. So we must have these things also in our mind. What are the treatment options for managing fibroids medically? Like surgical fibroids are small, or what size of fibroids patients you can recommend medical management or conservative management around 40 years of women. Is there any role of medical management?
Dr. Suresh, you can take up.
Yes, madam, actually, there is definitely a role of medical management since she is just 40 years. So definitely, and if the largest fibroid is subserosis, which is not causing any pressure symptoms, and small multiple intramural fibroids, first of all, we can correct anemia and reduce the blood loss by using tranexamic acid, and then we can use this the latest GnRH antagonist, which is be very helpful to reduce painting of fibroids.
Yes, and how many of you are having the experience of LNG IUD in the cases of fibroids or adenomyosis? Are they helpful? We can use it.
Yes.
For adenomyosis, it can be
the
useful.
LNG Marina, if the cavity is not distorted, and if it is an adenomyosis or a type 6, type 7 fibroids, which is small or multiple, definitely placing an LNG IUD is very helpful, ma'am. That is going to reduce the bleeding or cause amenorrhea, and it causes the shrinkage of adenomyosis. So definitely it plays a role, ma'am.
So here it is very clear that once the patient, of course, symptomatic treatment, sometimes we require NSAID, tranexamic acid, and on the other hand, GnRH analog, of course, they are using only for short period, either pre-operatively in some cases of infertility or before doing hysto or laparoscopic surgery, or to reduce bleeding and correct anemia, but they are not permanent treatment. GnRH antagonists also relieve menorrhagia, mifepristone and uripristal acetate. These are the two drugs. So, what should be used and when? Anyone wants to take this question?
Mifepristone and ulipristal acetate is given only for pre-operative management to reduce the size of the fibroid, as well as to take time for surgery to correct anemia, to correct bleeding, because long-term giving this mifepristone and ulipristal has no effect. So for short-term, for pre-operative management, for the preparation of patient, definitely it helps a lot before
Yes.
a corrective surgical management.
Nowadays, new drugs like GnRH antagonist, that is
Dr.
anabolized.
Priya was nodding her head, so let her give her opinion and then Dr. Suresh.
Yes,
Okay.
ma'am. Actually, I mean, I disagree with that because we don't use it pre-op for both the mifepristone and the ulipristal. It has been like, promoted by the pharma industry. They come and say, you can give it as long as the patient wants, just take years together, nothing happens. The only thing with ulipristal is that you have to monitor the liver function test. If you're not going to monitor, they can have an impact on the LFT there. It can get deranged. So so you have to tell them that every month they have to have a LFT. I honestly tell them, the moment I tell them, they say, no, doctor, I don't want the drug. Let the fibroid be with me, and they leave my clinic. So, that is not much used there. But I don't think anybody, I've not used it for that because the one thing is GnRH agonist, we all use it for pre-op to reduce, but only when you want to do a hysteroscopic myomectomy where you want to shrink the size and do the hysteroscopy and do it in a single setting. For laparoscopy, that is a different view. I think most of the lap surgeons will agree with me because the plane gets lost. So it is not very easy. Once your pseudocapsule gets lost, your plane gets lost, it is very difficult to get your myoma outside, and there can be some degenerative changes and becomes very difficult to get it out. So, whenever there's a plan on a surgery, I don't think we need to give any pre-op medications. Just go give the, hematamic corrections and then go ahead with the surgery. Dr. Suresh, your views?
Yeah, madam. Personally, I go only with the tranexamic acid. If that fibroid menorrhagia is responding to the tranexamic acid, then it's fine. Otherwise, she is for the surgical intervention. Rest all other drugs just to buy the time till the moment the patient is taking the mifepristone and ulipristal, she is amenorrheic. Once we stop it, she again starts with the menorrhagia. So personally, I'm not much in the favor of all those medications because they just change the size, and actually whatever the patient observes, these are the uh, inter these are the variations. If we do ultrasound now, it's 4 by 5 centimeter. After 3 months, that might be 3.8 by 3.5 centimeter. That doesn't mean that that had been shrink, but it's the inter observer or the variations. So
True,
for me,
Dr. Suresh, yeah.
if it's if it's responding with the tranexamic acid, it's fine. Otherwise, she's for surgery.
Yes.
Anyone want to add, please?
If failed means you are going for surgery. Otherwise, medical management is good means you can proceed.
So
So
for
many
patient
asymptomatic
fine
patients.
time, we can give medical management, madam. In case if it is a 49, 50-year-old, you know that there is no chance for malignancy. Just a little bit of a small fibroid which is causing her a symptom, and maybe another year she's going to go into menopause. So for those are the patients that come back, and that is where the elagolics come into play. Actually, it has a very good effect on the bleeding as well as the pain. Though some people have pain, like after elagolics as well, but most of them, they respond beautifully, especially when there is fibroid and adenomyosis together. So these, when the fertility is not the concern and they just want this pain to go off and not ready for Mirena or any other surgical methods, they just want this pain to go off. And now we have the recent combination, which is nothing but the religolics with the add back therapy. So it is a combination of this religolics along with estrogen progesterone combination. So they say that whatever the GnRH has a suppression, when you add this estrogen progesterone, so it counteracts the bone mineral density component of that, and the patient feels better. That's a new drug which we have not tried, so that is just coming into the market, the relugolics.
And besides that, we should know the options that like minimal invasive and ablative therapies. Of course, there are options in very certain cases when indications are there and where the facilities are there. Because we are always for safe uterus, so we want that uterus should be saved if possible. Patient-centered outcome and quality of life focus. Of course, we all know, and nowadays the technical and imaging advances are there, so we can map, we can do the correctly know the location of fibroid, size of fibroid effects on the woman's health. So accordingly, we have to manage. So uterine artery embolization, nowadays it is available At many places, the sonographic guided procedure, and in the heavy bleeding symptomatic fibroids, because it embolizes the artery, limits the bleeding, so have a benefits of that. That is a but where it is available, and it is not commonly available for everywhere. So any one of us panelists, they have experience of it. Though I have in the seen the
Madam,
patients in the big center, but Dr.
Actually,
Suresh, you have?
we are given an uterine
madam.
artery
In my hospital, in my
embolization as a study in a PG period for 20 patients for a fibroid patients for a gynec cases where to see whether the fibroid volume shrinks and how was the follow-up. Most of the patients had pain and degeneration, and few of the patients were very good tolerated when the fibroid is FIGO type 6 or type 5. But if it is going to be bigger fibroid causing pain and necrosis, and if it is sometimes because of the pain, we need to go for a second sitting or hysterectomy. And it is more suitable for the obstetric procedures for the placenta previa or for that conditions it is more helpful, ma'am.
APH.
Gomadi is disturbed the voice. Anyway.
Dr. Suresh, you want to add something?
Yeah, ma'am. Personally, I feel those who were the symptomatic fibroid, I mean, we're having a facility for uterine artery embolization in my medical college. But unfortunately, we found that those women who were symptomatic, they never responded with this uterine artery embolization.
Right.
Neither the reduction in the size or neither the symptoms.
So nowadays we are not going for this uterine artery embolization also. Okay.
Yeah.
So there is a one important slide that what are the potential risks if woman is not remain untreated, menopausal, postmenopausal women and or perimenopausal women having the fibroid. As it is said that not active management is required. So one has to be told very clearly that clear communication about the benign nature of fibroid and address patient concern, ensure that patients are informed about the low likelihood of malignancy and typically manageable risks associated with untreated fibroid. So that fact should be always keep in mind. And malignancy risk, while the risk of malignancy in fibroid is low, but use ultrasound for initial diagnosis and consider advanced imaging if malignancy cannot be definitely ruled out. Regular monitoring is crucial because in the last 2 years, I have seen 2 or 3 cases of my very close patients, those who have the fibroids around the age of 45 and that was not symptomatic, that was found accidentally, and they have kept it that menopause would be there and they would be regressed, but after 1 or 2 years of menopause, they have some spotting and their endometrial biopsy is done. That was normal, but because of some spotting, there is hysterectomy done, and on the hysterectomy sample, they have uterine sarcoma. So we have to be very careful for monitoring or follow-up of these patients. And of course, regular monitoring fibroid size and any symptom that may develop, consider intervention if significant growth of new symptom occurs. Pregnancy and infertility, of course, assess the impact of fibroids on pregnancy and fertility of an individual case. Those in young patients, we are keeping on the conservative management, then we have to take care of these things. Consider intervention for fibroid that causes complication during pregnancy and impacts fertility. So this is the important message. And the last case that the 55-year-old female.
1 minute. Dr. Priya, there is one question. GnRH agonist, do you prefer in the reproductive age group with subfertility?
No. GnRH agonist, no, because the surgery is the better option for them. Because, I mean, especially for submucous and intramural. But sometimes, madam, even if the intramural size, just an intramural alone, 4 to 6 centimeters, a patient is recently married, not tried much, or maybe like, just 1 or 2 years of subfertility, and we don't know like whether the fibroid is the cause. I give them a few cycles of ovulation induction, try, and then only go for surgery, rather than thinking that the fibroid is the reason. If it is very large fibroid, then I do surgery initially. But if it's a little smaller size, I try a few cycles, then only opt for surgery, ma'am.
Yes, that was the question asked by Dr. Vinodini. Okay, Bhati, go with the last case.
Okay. So, like, madam, we also use the GnRH antagonist only before, if someone requires, before surgery to shrinken the fibroid size. So now for 55 years old female, attained menopause 5 years back, come to OPD with chief complaint of pain, noted for 6 months. That and abdominal lump also. She was gradually increasing in size. Occasionally pelvic discomfort and urinary frequency. No history of postmenopausal bleeding. On the history, you find that there is a no significant past gynec illness, no HRT, no family history of malignancy. On investigation, ultrasound pelvis and large uterus with multiple fibroids, largest is 6 centimeter, partially calcified. Confirmed fibroids MRI, no suspicious feature of sarcoma. Endometrial biopsy is done, atrophic endometrium, no hyperplasia, malignancy, CBC, renal, liver function, they all are normal. So, what should be the approach and what should be the management in this cases? Anyone?
Postmenopausal, we expect the fibroids to shrink, madam. So if the fibroid is growing in a postmenopausal woman, I will think of sarcoma, even if the MRI is saying no. Maybe not today, maybe few years or few months, you can go and get a sarcoma there. So I will counsel the patient saying that there's an increasing fibroid even after menopause. So it is better to get the hysterectomy done, and it's multiple fibroid and the largest is 6. So I will also see the overall size of the uterus. So if it's a bigger one, I will definitely plan for a surgery.
Nice, fantastic.
True. So very true. And of course, these things we should taken care of because sometimes patient is not so symptomatic. So we think that fibroid can be left, but again, the high risk cases for the sarcoma, we have to begin. And this is the figo-leiomyoma classification system. Already, Dr. Priyanka has told, so we should know to decide the management of fibroids. That how we can do figo stages of fibroids as well as we should do that what staging of fibroids, and then we should manage accordingly all proper documentation. And what are the atypical fibroids at different locations? And we have phase fibroid ligaments, ovarian fibroid, uterosacral round ligament, vulva, vagina, parenthetic, etc. So which is the considered as a diagnosed extent of submucosal fibroid in uterine cavity, which is considered as a gold standard technique to diagnose the extent of submucosal fibroid in uterine cavity. Anyone? Of course, hysteroscopy, I think.
Hysteroscopy,
And
we
this is
don't take
also
it for diagnosis, madam. We take it in a single setting. You diagnose, and if you see it there, you treat it in the same setting. So you go with the
Yes.
consent accordingly, because we cannot put a diagnostic scope and then go ahead and operate. So if you just have to have a dual consent saying that if we find a fibroid, we will then and there operate on you. So with that,
depends on, but many are using office hysteroscopy. So hysteroscopy is the gold standard
yeah,
for
so
diagnosing and evaluating the extent of submucosal fibroid. And then we can decide that what type of surgery and by whom we have to go, and we can plan also. But as you are saying that it can be
if
done
you
in the
have a
same
good
setting,
setup in ultrasound, I think your
Saline
ultrasound most
infusion
of the time will
sonography.
be for, I mean, within the cavity.
Saline infusion sonography plays a very good role in a small setup where office hysteroscopy is not available, ma'am. It definitely helps to pick up even a small submucosal fibroid or a polyp.
And we have 3D ultrasound, madam. So whenever we do a pelvic ultrasound, we put a 3D sweep. And most of the time, like, if it's a small fibroid in the cavity, we just pick it up then and there. So, like that will also help us. And saline, yes, even in spite of that, sometimes we have doubt. Whenever you have pedunculated, it's picked up beautifully in 3D. But whenever you have a sessile fibroid, where it's going to be like, just sitting there, it is definitely not picked up. You may just have a suspicion it's not picked up. That time, if you put a saline and then you do a 3D sweep, you will definitely see the indentation and very beautifully you'll be able to pick it up.
So we are about to end on the panel. Anyone want to add? But again, what we have all observed that of course incidence of fibroids are increased. As in fact, in the last RART batch, we have seen that once we have started the treatment, we have not found fibroids. But once we have done ovulation induction until we are planning for the ET, तो उसके पहले सबके अल्ट्रासाउंड में छोटे 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 small fibroids. So I just observe and I will further observe कि क्या ये इतने बीच में any medications if it's say operation induction medicine कि they all have fibroids. So my team was saying that, madam, ये छोटा fiber 3 centimeter का है, वो 5 centimeter का है. And besides that, the patient is always remain apprehensive. Madam, ये छोटा सा गोली है, रसौली है, इसके बिना से तो नहीं रुकेगा, इसको निकालने का जरूरत तो नहीं है. So something like that, and many medical treatment options, of course, as Dr. Suresh and we all are agreed that actually they are not very much helpful in the symptomatic fibroids because they didn't give permanent treatments, and finally we have to remove the do the surgery. But for time being, of course, or for the psychological effects, when we don't need surgical treatment, then patient is being taken. So thank you very much all esteemed panelists, and I'm really very glad to meet all of you because most of you, Priya, I know, but Sadhana Devi, madam, I met you. I think we met in some conferences, but in the webinar, Dr. Gomati, nice to meet you. Dr. Suresh, nice to meet you. So thank you, Dr. Sampat Kumari, madam. Take home message by our experts for all audiences for fibroid management.
Anyway, thanks to Dr. Komati, Sadhana Devi, Suresh, and Priya. Priya was last entry, replacing Dr. Radha Madhavi. Dr. Suresh, sir, it's very nice to have the fantastic panel. Yes. Bharti, you did a good job.
Thank you.
Covered from adolescent to post-menopause. Covered.
Thank you. Thank you.
Covered every aspect of fibroid, madam. Excellent.
Thank you very much, and
Thank you, ma'am.
always nice to meet all of you.
Thank you so much. Thank you.
Dr. Madhumita,
Yes, ma'am. Thank you so much, Bharti ma'am, for this wonderful panel with your panelists. So moving on to the end of the session. So first and foremost, I would like to thank Professor Sundaram ma'am for this series. I would like to thank the presidents of President Secretaries of Meerut Society, Dr. Bharati and Dr. Priyanka, Jharkhand Society, Dr. Shashibala and Dr. Archana Kumari ma'am, and Aurangabad Society, Dr. Ajay Mane and Dr. Bhagyashree, and Oxy Society, our Sampath ma'am and Dr. Meena for coming together for bringing us this wonderful session. And I especially thank our guest of honor, Dr. Rusha Sharma ma'am, Dr. Rajendra Singh Pardesi sir, and our guests of honor, Dr. Ajay Mane and Dr. Shashibala. And our first session speaker, Dr. Priyanka Garg, gave us a wonderful insight into the vaginal surgeries, tips and tricks. And the chairperson of the first session, Dr. Archana Kumari, and the wonderful panel moderated by Dr. Bharti Maheshwari. And our dear panelists, Dr. Gomati, Dr. Sadhana Devi, Dr. Priya Kannappan, and Dr. Suresh for your excellent inputs. And I would also like to thank Shri Events, Shri Priya and Sahiti for your for the excellent coordination without any technical glitches. And I would like to thank our dear audience for joining in large numbers and gracing this webinar series. Thank you everyone once again.
Thank you, Dr. Priya and Dr. Madhumita for all the speakers, panelists, and the society. Thank you, thank you, thank you, Sakiti. We will put the link in the group. You can share in your place. Also, the link of this webinar will be posted in the group. Thank you. All have a good night.
Thank you.
Happy Dasara.
Thank you, everyone.
Thank you. Thank you.
Thank you, ma'am.